Welcome to this session on anti-cancer drugs. Chemotherapy, cancer chemotherapy we call it. Chemotherapy actually is a general term that is used for all types of antimicrobials also, but when we say chemotherapy, the impression goes that we are talking about anti-cancer drugs. If we see the history of anti-cancer drugs, this actually started almost 50 years after the discoveries of antibacterial or antimicrobial agents. The reason may be because we did not understand much about the cancer, and one of the advantages with antimicrobial drug was that we could stain the bacteria selectively. Anti-cancer concept could not evolve because these cells were a part of our body. They are basically our cells. They are not foreign cells like bacteria or others. So if we see, it started late, and even now the selectivity of anti-cancer drugs is not as much as is there with antibacterial drugs. This actually you can think of antiviral also. Even that concept could not evolve as much as antibacterial. The reason the virus uses the metabolic processes or the cells of the host to multiply and to grow. But even more than that, if we see anti-cancer cells, they are not utilizing our cells, they are our cells. So it was not possible to differentiate them, and so when actually the drugs were also came, like in 1940 somewhere, nitrogen mustard, this was during Second World War. Actually this discoveries of anti-cancer drugs, this you will find the concept evolved during Second World War, when the war gases were being tried, like cytotoxic substances were being tried so that they could be used as for chemical warfare. And at that time this was found out, and many of them actually, these drugs, they were discovered at that time, but they were used as anti-cancer drugs later on in 60s. So nitrogen mustard, that was a cytotoxic drug that was developed. But if we see comparatively, during last 50 years the concept evolved a lot. And now actually in last 20-30 years our understanding of cancer, it has increased a lot. Otherwise, if you see in 60s, 70s, what we were doing, we were trying to kill the cells known specifically, and how to get the selectivity that only cancer cells are killed, that was only that the rapidly multiplying cells will be killed. So what we were doing, we were starving the cells. So those which are multiplying fast will starve first, and those which are not multiplying, they will remain normal for and the cancer cells, because they are multiplying very fast, and this is not exactly like following the whole processes, and because of that they could be eliminated comparatively more selectively, but these drugs are very toxic. But if we see in the last 20-30 years, we are coming up with lots of concepts of antigens, oncogenes, by which we can selectively target the cancer cells. So things are changing now fast. So even now if you see chemotherapy, this is like we are giving drugs for treating the cancer. There are other modalities also for treating the cancer, like if it is a solid tumor, we can go for surgical removal. What would be the advantage? Suppose I have 100% cells, carcinogenic cells, I remove 80% of them by surgical resection, then what do I have to treat with drugs? Only 20%. And so this would be very helpful. Radiotherapy, if I have removed the cells also and I have given radiotherapy also, so out of the 20%, 10-15% are also gone. So what will remain after surgical removal and radiotherapy, I will mop them up with chemotherapy drugs. So remember, chemotherapy can be used as an adjuvant also to surgery, to radiotherapy, and it can be a primary modality, like say in case of leukemias, lymphomas, you cannot go for surgery, you cannot go for radiation, so you have to go for chemotherapy only. So in those cases you have only chemotherapy. And so we have to understand this concept of, and otherwise also some of the carcinoma, remember carcinoma is not a general term, there are very specialized cells depending on from where it is evolving, and after that also this undergoes mutations. Like the cells, when they are multiplying fast, they keep changing some of the characteristics, and so some of the carcinomas, some of the cells are very sensitive to chemotherapy, others are not that sensitive. So there are many considerations. Actually this is a very primary consideration. If we see, there are certain carcinomas, there are certain cancer cells which are very sensitive to chemotherapy, to these drugs, and this can actually, we can call it cure. The person can be cured, means there are very long remissions. These are carcinomas like acute leukemias in children, these are in children, acute leukemia, Wilms tumor, Ewing's sarcoma, retinoblastoma, rhabdomyosarcoma in children, and in adults there are cancers like choriocarcinoma, Hodgkin's, seminomas, testicular teratomas, mycoids, fungoids. So these are carcinomas which are very sensitive to the drugs. So chemotherapy is very effective against them. On the other hand, there can be some carcinomas which cannot be cured, but they are sensitive to drug, and the drug can cause prolonged remissions, like for a long time there will not be. Remember, the problem with cancer is, even if a single cell remain, the cell has the power to multiply and again create carcinoma. That is the problem. So if when we say cure, means 100%, all the cells must be killed, but that is not possible, because see, cancer cells, they have different characteristics, not uniform, as I told you. Even if it is originating from one organ, the characteristics of all the cells is not same. Some of them they are killed fast, some of them they will be killed slowly, some of them they will become resistant. So we try to eliminate as much as possible. If 100% is removed, then we can say it is cured, but in other cases we can kill 99% of the cells. And so even if the disease comes back, it would be after a long time, and these are these carcinomas like say breast carcinoma, ovarian, endometrial carcinomas, prostate carcinomas, non-Hodgkin's, chronic myeloid leukemia, chronic lymphoid leukemia, head and neck cancer, small cell carcinoma of lung. These are the carcinomas which cannot be cured with chemotherapy, but there can be prolonged remissions, or we can call it palliation also, like for a long time the person will be free of the disease. And there are some carcinomas which are not sensitive or very less sensitive to chemotherapy. These are carcinomas like colorectal, stomach carcinomas, esophageal carcinomas, pancreatic carcinomas, renal carcinoma, bronchogenic carcinoma, non-small cell carcinoma of lung, hepatomas, sarcomas. So many of these are not sensitive to chemotherapy, and that is why actually the survival rate is very less in these diseases. First thing we have to understand before I go into general toxicities and other considerations, first of all, the most important thing in anti-cancer drugs is to remember them, to remember the classification, or to remember the list of anti-cancer drugs. And we have to find out some mechanism to remember all of them, and classification is the best way to do that. So remember, all the anti-cancer drugs or chemotherapy, cancer chemotherapy drugs, broadly you can divide them into cytotoxic drugs, targeted drugs, and hormonal drugs. Broadly, cytotoxic, targeted and hormonal. In cytotoxic drugs, you can classify them, these are classical drugs, we can classify them as alkylating agents, platinum coordination complexes PCC, antimetabolites, microtubule damaging drugs, topoisomerase 1 and topoisomerase 2 inhibitors, antibiotics and miscellaneous. See, cytotoxic divided into 7: alkylating agents, platinum coordination complexes, antimetabolites, microtubule damaging, topoisomerase 1 and 2 inhibitors, antibiotics and miscellaneous. We have to mug it up. Then we'll come to know about further divisions of this. Alkylating agents. Alkylating agents are classical anti-cancer drugs, and they are further divided into, remember the first drug I told you was nitrogen mustards. Nitrogen mustards, they are very first drugs, anti-cancer drugs which were used. I have not used that the way they were discovered. This is a sort of mnemonic. The man. This is the way we can remember it. The man. T, triazines. H, hydrazine. It is methyl hydrazine. Ethylenimine. Nitrogen mustard. So mustard nitrogen. Alkyl sulfonates and nitrosoureas. The man. Now we'll see the examples of these drugs, of these classes. The THE, the triazine. Triazines are dacarbazine, temozolomide. Dacarbazine and temozolomide. And methyl hydrazines are procarbazine. Remember, we always remember procarbazine, dacarbazine. No problem. But structurally they are different. Remember, hydrazine and triazine is a ring structure. Hydrazine is an open structure. So they were, the names we find similar. We'll see other cases also. But they are structurally very different from each other. So remember, triazines are dacarbazine, temozolomide, and hydrazine is procarbazine, methyl hydrazine. Ethylenimine, thiotepa, very old drug, and then came ultratamine. Thiotepa and ultratamine are ethylenimine. Then man, M, mustard, nitrogen mustard. Nitrogen mustard also we can remember CM meets CBI. CM meets CBI. Cyclophosphamide. Mechlorethamine. Mechlorethamine is the first drug that was discovered. We also call it in many places, what is written is mustine. Mustine basically meant for nitrogen mustards. Nitrogen mustards, they have this common group that is universal to this thing, nitrogen mustard group we call it, that is very typical. This is the active group, that is nitrogen mustard. So we find it in many drugs and they are known as mustines. So mechlorethamine, cyclophosphamide, CM meets melphalan, MELPHA, melphalan. CBI, chlorambucil, bendamustine. Bendamustine. Why I am stressing here mustine? Because we have a separate group, nitrosoureas, carmustine, lomustine. But we identify this mustine with that group. But remember, mustine basically is meant for mustards, nitrogen mustards. So those drugs which are having other characteristics also, but they have this characteristic also, we call it mustine. So this is bendamustine. We have here E-phosphamide, cyclophosphamide, E-phosphamide, mechlorethamine, melphalan, chlorambucil, bendamustine. Okay, so these are nitrogen mustards we have. And I am talking about alkylating agents. This is the classification of alkylating agents that we are talking, the main. So mustard. And then alkyl sulfonates, busulfan, and nitrosoureas, as I told you, carmustine, lomustine, carmustine, lomustine. So these are all alkylating agents. Then which are the other cytotoxic compounds? The other cytotoxic compound is this platinum complexes, cisplatin, carboplatin, oxaliplatin. Cisplatin, carboplatin, oxaliplatin. Then we have antimetabolites. Antimetabolites are divided into three groups. One is folate antagonist, second purine antagonist, third pyrimidine antagonist. Antimetabolites, folate antagonist, purine antagonist, and pyrimidine antagonist. So folate antagonists are methotrexate, we all know, and pemetrexed. Pemetrexed. It is not pemetrexate. Pemetrexed. We have to remember. Then purine antagonists. Fat man. Fat. Fludarabine, an oral preparation of mercaptopurine. Fludarabine, azathioprine, 6-thioguanine, and 6 mercaptopurines. Amongst these, 6 mercaptopurine is the oldest. But just to remember this, fat man, fludarabine, azathioprine, thioguanine, and mercaptopurine. 6 thioguanine, 6 mercaptopurine. And pyrimidine, FDCGC. FDC, good company. 5-fluorouracil, doxyfluoridine, an oral preparation. Doxyfluoridine, this is also fluorouracil only, fluorine containing only. Doxyfluoridine, cytarabine, very old preparation, cytarabine, gemcitabine, and capecitabine. Okay, FDC, good company. 5-fluorouracil, doxyfluoridine, cytarabine, gemcitabine, and capecitabine. So we have to remember these are pyrimidine. Then we have microtubular damaging drugs. These are two groups. One is vinca alkaloids. Vinca alkaloids are vincristine, vinblastine, and vinorelbine. Very old preparation, very old drugs these are. Vincristine, vinblastine, vinorelbine. And taxanes, again very old, paclitaxel and docetaxel, paclitaxel and docetaxel. And this is a separate drug that we'll have to remember, estramustine. See, again this is mustine. It is basically estramustine. You can remember estra means estradiol, estrogen, and mustine is as nitrogen mustard properties, nitrogen mustard group. But this is microtubular damaging drug. So this is a separate drug that we'll have to remember, estramustine. Then we have topoisomerase 1 inhibitors, that is topotecan and irinotecan. Topotecan and irinotecan are topoisomerase 1 inhibitors, and topoisomerase 2 inhibitor is etoposide. So these three drugs are topoisomerase inhibitors. 1 topotecan irinotecan, 2 etoposide. These are topoisomerase inhibitor, and these are antibiotics. Mitomycin C. Mitomycin C, made in Bharat. This is how I remember it, made in Bharat. M, mitomycin C. A, actinomycin D. D has two drugs, doxorubicin, daunorubicin. They are basically adriamycins. All these four drugs, doxorubicin, daunorubicin, epirubicin, idarubicin. Traditionally there were only two, doxo and daunorubicin. Now we have epirubicin and idarubicin also. So if you want to remember all of them as rubicins, you can do that. Then it becomes MARB, MARB. Mitomycin, actinomycin, all these rubicins, and bleomycin. Bleomycin, this is an antibiotic. And then finally miscellaneous, hydroxyureas, arsenic trioxide, L-asparaginase, and tretinoin. Halt. That is why I have written them like this. Otherwise, hydroxyurea, L-asparaginase is most important among them. So, hydroxyurea, arsenic trioxide, L-asparaginase, and tretinoin. These are miscellaneous. So these are all what we have talked about. They are known as all cytotoxic drugs. Remember, cytotoxic drugs we had grouped into first one alkylating agents, number 2 platinum complexes, number 3 antimetabolites, number 4 microtubule damaging drugs which were vinca alkaloids and taxanes. We had topoisomerase inhibitors, we had antibiotics and miscellaneous. So these are all cytotoxic. Then we have targeted drugs. MCR, ABL, tyrosine kinase inhibitors. Remember, they are TKIs. Tyrosine kinase inhibitors, BCR, ABL, tyrosine kinase inhibitors. Second group is EGF, HER receptor inhibitors. So they are receptor inhibitors. EGF receptor inhibitors, ER inhibitors we can remember. Angiogenesis inhibitors are there. Proteasome inhibitors are there. CD20 inhibitors and immunomodulatory imides or imides. So what is this? What is this? TKIs, tyrosine kinase inhibitors, E receptor inhibitors, angiogenesis inhibitors, proteasome inhibitors, CD inhibitors, and immunomodulatory imides or imides. So TRAP IC or TRAP CDI or TRAP ICD, tyrosine kinase inhibitors, receptor inhibitors, angiogenesis inhibitors and proteasome inhibitors, TRAP. What is TRAP? Immunomodulatory and CD20 inhibitors. So which are these drugs? Tyrosine kinase inhibitors. Traditionally, this was, I used to remember it as DIN. Dasatinib, they are all tinibs. Dasatinib. Imatinib is the oldest. Imatinib and nilotinib. So this became DIN, and then recently this came CBC. Crizotinib, bosutinib and cestinib also is there. Crizotinib, bosutinib. So you can remember as many of them as you. So dasatinib, imatinib, nilotinib, crizotinib, bosutinib, cestinib. You can remember as many of them as you can. Then these are EGF receptor inhibitors, HER1 and 2 actually. Leg-CT, lapatinib, erlotinib and gefitinib. Gefitinib is the oldest one amongst them. Leg, lapatinib, erlotinib and gefitinib. And these are two Zumabs, MABs. One is trastuzumab, the older one, and second is cetuximab. Okay, trastuzumab and cetuximab. Remember, some of them are like HER1 inhibitors, and this trastuzumab and lapatinib, they are HER2 inhibitors, but they are receptor inhibitors, EGF receptor inhibitors. So you'll have to remember all of them. Lapatinib, leg, lapatinib, erlotinib, gefitinib, cetuximab and trastuzumab. And then angiogenesis inhibitors, TRAP, angiogenesis inhibitors, A for angiogenesis inhibitors. This I don't have any mnemonic, but this I remember from this Sunitinib. Second one, sorafenib. So this is basically tinibs are, but this because of this IB and Suniti. So Sunitinib, sorafenib and bevacizumab. Bevacizumab. This is just a way to remember, bevacizumab. And proteasome inhibitors, this I remember from, there used to be one very famous cricketer, Chandu Borde. So this is Borte and Jombi. So Borde Jombi, this gives me this Borte Jomib. Borte Jomib is proteasome inhibitor. Then we have immunomodulatory imides, this classical thalidomide and lenalidomide. Thalidomide and lenalidomide. So this is just some methods to remember these names. And then we have hormones, hormonal drugs. Which are the hormonal drugs? Glucocorticoids. In most of the regimes you will find either prednisolone or dexamethasone. So glucocorticoids. Estrogens, we know there are some estrogen, some tumors are there which are inhibited by estrogen. Selective estrogen receptor modulators, and there are selective estrogen receptor inhibitors, but they are all classified under SCRM. Aromatase inhibitors, anti-androgens, 5-alpha reductase inhibitors, GnRH analogues and progestins. These are all hormonal drugs which are used as an anti-cancer drugs. So glucocorticoids, I told you, prednisolone, dexamethasone, all are used. Estrogen, ethinyl estradiol, and many others are used. SCRMs, tamoxifen, toramifen, and this fulvestrant. Fulvestrant is basically inhibitor of selective estrogen receptor. So fulvestrant. Aromatase inhibitors are letrozole, anastrozole, and this exemestane. Remember another drug with exenatide, if you remember. This is exemestane. These are aromatase inhibitor: letrozole, anastrozole, and exemestane. Then we have anti-androgens, flutamide, bicalutamide. We have read it at relevant places. Flutamide and bicalutamide. Then we have 5-alpha reductase like finasteride, dutasteride. They are used as an anti-cancer drugs. GnRH analogues, LNT, I remember, leuprorelin. This is the common, leuprorelin, and it is RELIN. There is no E in the end. Leuprorelin, nafarelin, triptorelin. So LNT, leupro, nafa, triptorelin. And then we have progestins like hydroxyprogesterone, and other progesterones are also used as anti-cancer drugs. Then we have to remember all these drugs, then only we can proceed further. So we have to mug it up, then only, because whatever we are talking about, we are giving examples of these drugs only. Now in general considerations, what is most important thing we have talked about, like they could not be developed so fast, and these drugs are very toxic because it is very difficult to select the cancer cells. Cancer cells is like our own body cells. So whatever drug I am using, that will kill my own body cells also, and not only cancer. And that is why toxicity with anti-cancer drugs is an integral part of it, and we have to tolerate it. There is no anti-cancer drug that is not toxic to our body. Some of the toxicities are generalized, and some of them are very specific. The specific ones you will read when we talk of in the next lecture, when we talk of specific drugs. What we are concerned about today are generalized. And as I have told, these are non-specific drugs, so they will kill all the cells which are multiplying fast. If it is cancer cells, this would be therapeutic action. If it is normal cell, this will be a toxicity, but this will not be able to differentiate. So which are those generalized toxicities? Bone marrow, fast multiplying, it is constantly producing various types of cells, so there will be suppression of bone marrow. There will be agranulocytosis, there will be aplastic anemia also in some cases, there may be granulocytopenia. So all types of bone marrow suppression symptoms will be there. Lymphoreticular thrombocytopenia will be there. Various cells will be inhibited, and both these will lead to what? Increased tendency for infection or increased susceptibility for infections. Remember, there can be various types of infections, right from fungal candidiasis to opportunistic infections. There can be even these super infections, viral infections. Herpes zoster is very common. Pneumocystis Girovesi is very common. So all these infections, they are very common in these toxoplasmosis. They are very common in the people who are taking chemotherapeutic agents. Oral cavity and GIT. Remember, our oral cavity and GIT, we are chewing in the mouth and the food is being processed in the GIT. There is lot of wear and tear in the mouth when we are chewing. Many cells and many cuts and so many things are happening. That is why the mucosa of mouth, it needs constant replenishment. When the person is undergoing chemotherapy, there will be ulcers. This will not be, and over that, this. So there will be infections in the gums. There is xerostomia also by many of these drugs, will lead to caries also in these individuals. And when see other parts of GIT, the mucosa of other parts of GIT is also vulnerable. There will be ulcerations in the mucosa because this is being constantly being replenished. So this will lead to diarrhea, dysentery, all types of sloughing of mucosa of GIT. Melena will be there, bleeding will be there because thrombocytopenia. There will be bleeding from gums also, there will be bleeding in the intestine also, so there will be melena. So all these problems are going to be, and remember, this is not the choice that some people will have it. What we are talking about in general considerations is everybody will have these problems with anti-cancer drugs. Hair follicles, alopecia. This is basically synonymous with chemotherapy, and many people are, you will find many influencers also, they are creating awareness about it because the hair follicles are growing, multiplying very fast. So hair fall, alopecia is a characteristic of cancer chemotherapy. So there will be alopecia also. And some other problems like say fetus. This would be lethal. There will be either abortion or there will be teratogenicity in the fetus if it is taken during pregnancy. Hyperuricemia. So many cells are being killed, particularly say in leukemia and other thick tumors. So many cells are being killed, and this uric acid is a product of purine synthesis. So hyperuricemia, hypercalcemia. Again, so these are the problems that we find, and actually secondary carcinoma. It is been seen in many carcinomas that after they are treated, several years after that, some leukemias they develop. This is because the long-term effect of many of these medications. So all these are generalized effects of anti-cancer drugs. What do we do to decrease these toxicities? Folinic acid. If we give folinic acid, we can increase the dose of methotrexate to even 100 times. This is basically, folinic acid is a salvage. The cells, they need folic acid for their own survival. So folinic acid is used, and that way we can increase the dose of methotrexate. Mesna and acetylcysteine. Remember, some of the drugs, they have very characteristic effect, like cyclophosphamide. Cyclophosphamide, it causes hematuria. And why this hematuria? It is because of a metabolite of cyclophosphamide. When it goes into the bladder, then there is cystitis, and there may be hematuria also. So these are SH containing. Acetylcysteine, we irrigate the bladder, and mesna we give orally. They are SH containing, and they detoxify that metabolite. So that way we can use higher doses of cyclophosphamide. ondansetron, vomiting. In this, remember GIT, emetogenic potential of anti-cancer drugs. You have to actually, this is frequently asked question, which are the drugs which are most emetogenic? Well, you have to remember it, which are the drugs which are most emetogenic, which are the drugs which are moderately, or some of them are mild. Remember, I can give you many mnemonics, but you have to find some mechanism. Remember, you have to remember 5-6 names in each category. So the drugs which are highly emetogenic, they are like cyclophosphamide. Amongst, basically, as I told you, there are many methods to remember. One is, if you remember the classification exactly, then you can remember amongst them, which are like, if you see in alkylating agents, nitrogen mustards. In nitrogen mustards, cyclophosphamide and mechloroethamine, they are highly emetogenic. And E-phosphamide, bendamustine, they are moderately emetogenic. And other, say, melphalan, chlorambucil, very mild emetogenic potential. This is the way you can remember. Cisplatin is highly emetogenic. On the other hand, carboxyplatin and oxaliplatin, they are moderately emetogenic. Amongst antimetabolites, 6-mercaptopurine and cytarabine. 6-mercaptopurine is purine antagonist, cytarabine is pyrimidine antagonist. They are moderately emetogenic, and rest of them, methotrexate and rest of these antimetabolites, they are mild emetogenic. If you see amongst these taxanes, you will find they are mild emetogenic. Amongst vinca alkaloids, vincristine is very mild emetogenic, vinblastine is moderately, we can classify. Among antibiotics, if we see doxorubicin, daunorubicin, this is moderately emetogenic. Actinomycin D is highly emetogenic, and rest of them like bleomycin, this is mildly emetogenic. The miscellaneous ones like hydroxyurea, L-asparaginase, they are very mildly emetogenic. These TNIBs, amongst tyrosine kinase inhibitors, TNIBs are moderately emetogenic. So this is the way, or you'll have to find some mechanism like I have call MCD, call actinomycin D, cisplatin, and lomustine. Amongst nitrosourea, remember lomustine is highly emetogenic and carmustine is moderately. So call C for cisplatin, A for actinomycin D, L for lomustine, MCD, mechloroethamine, cyclophosphamide, and dacarbazine. Remember, highly emetogenic, I am telling you cisplatin. Actinomycin D, lomustine, mechloroethamine, cyclophosphamide, and dacarbazine. These are highly emetogenic. Call MCD. If cisplatin is highly emetogenic, carboxyplatin, carboplatin, and oxaliplatin, they are moderately emetogenic. Actinomycin D is an antibiotic, highly emetogenic. Daunorubicin, doxorubicin, even the other epirubicin, iridorubicin, they are moderately emetogenic. Lomustine is a nitrosourea. Carmustine is moderately emetogenic. Meclorethamine cyclophosphamide, this is nitrogen mustards, highly emetogenic. So we have E-phosphamide. This is, I keep telling you that we have to remember the spelling. It is IFOS E-phosphamide, PHA. E-phosphamide, bendamustine, they are moderately. Dacarbazine is triazine, so moderately is procarbazine, that is an hydrazine. And amongst triazine, remember temozolomide, that is also moderately emetogenic. So at least this much you can remember, and rest of them you can remember they are mildly, like you can add here in moderately 6 mercaptopurine, 6 not 6, this is cytarabine, antimetabolites. So this becomes a list for moderately emetogenic, and rest of them you can add all antibiotics like methotrexate or fluorouracil. They are mildly emetogenic. Here one group vinca alkaloids I have told you, vinblastine, vinorelbine, they are moderately, vincristine is mild, and bleomycin, L-asparagine is miscellaneous, and hydroxyurea, you can club them under mild. But remember, if you remember this much also, that these are highly emetogenic, these are moderately emetogenic, you will be able to answer the question of emetogenic potential of anti-cancer drugs. So remember this. So we were talking about decreasing the toxicity. How can we decrease? So we are giving ondansetron. Remember, this emetogenic potential is also because of both direct action on CTZ, and because there are so many things happening in the GIT. So peripheral also is there. Ondansetron, you know, 5-HT3 receptor antagonist. So this is used, and this has to be used before giving anti-cancer chemotherapy. Dexrazoxane. Dexrazoxane is basically an iron chelator. It is seen that doxorubicin, daunorubicin, they have cardiotoxicity. And it is seen that when this is used, this is given before giving doxorubicin, daunorubicin, then the toxicity of doxorubicin, daunorubicin, cardiotoxicity, it is decreased a lot, significantly. But it is also seen that the effect of doxo-dauno, anti-cancer effect also is reduced. But this drug is dexrazoxane. Amifostine. Amifostine is basically a thiophosphate. In the body, it is activated by alkaline phosphatase, and then it becomes cytoprotective. Non-specific, generalized. So it's not only that because of chemotherapy, even if you are giving radiotherapy, the cytotoxicity, general cytotoxicity in all the places, but mostly in the GIT and other places, this is decreased. So this is a cytoprotective, amifostine, remember this. Then we have allopurinol. Allopurinol will decrease hyperuricemia. We know the mechanism. We have bisphosphonates. If there is hypercalcemia, there is osteoporosis. So we have to use bisphosphonates, we have to go for hydration. It is found that hydration and bisphosphonates, they can preserve the bones. Many a times, to avert bone marrow suppression or to take care of bone marrow suppression, we have to go for platelet and granulocyte infusion. After we give a cycle of chemotherapy, then we have to go for this infusion. We can use this colony stimulating factors also. Granulocyte colony stimulating factor like filgrastim, pegfilgrastim. We have to use in many cases. Or GM-CSF, sargramostim, molgramostim. We have to use. We in some cases have to go for bone marrow transplant also. And targeted delivery. This targeted delivery can be like if the carcinoma is of head and neck, I can give it in the artery. If it is in the limb, I can give the injection in an artery. Or there can be targeting by other methods also, but we can give targeted delivery so that all the cells of the body are not affected by that agents. So these are various mechanisms by which we can decrease the toxicity. Then few points about considerations in chemotherapy, general considerations in chemotherapy. Remember, we have talked about some cells are very sensitive, some cells are less sensitive, some cells are not sensitive at all. So we have to decide in which case we have to go for chemotherapy, or we have to go for surgical removal, or we have to go for radiation. But as we have talked about, chemotherapy can be given after surgery and radiation also to mop up all the cells which are left in the surroundings, because the problem with surgery is you cannot remove all the cells. Even if we say that the whole tumor is removed, some 20% of the cells will remain in the body, and maybe the cancer has metastatized. That is another problem. So radiation also cannot kill all the cells. So chemotherapy is very important. So that is one thing. Second thing is that chemotherapy is given in cycles. When we have decided that we will use chemotherapy, either it may be a primary mode or it may be adjunct to other modalities, but whenever we give chemotherapy, we always give it in cycles. Why is it so? Because we allow the body cells to recover. Remember, when we are giving chemotherapy, we are suppressing all the cells. So basically they are poisons. They are generalized cytotoxic drugs. So we have to give a chance to the person to recover its normal cells which are important, like bone marrow or in GIT or in other places. The opportunity has to be given to those cells to recover. And when we give these in cycles, what happens? We say that it is proportionate killing. So if I give this drug in half the strength, then 50% of the cells are killed. If I give increased doses, then more number of cells will be killed. So what is the strategy? Is to give higher doses in cycles, then give some time for the body to recover, the other cells of the body to recover. Another important thing is that we do not go for a single drug. We always go for a group of drugs and we call them regime. So there are various regimes which are given in the book. They are specific for specific type of carcinomas. But what are the characteristics of these regimes? Remember which are the drugs to be added in a regime. So some general considerations are there, like these drugs should have different mechanism of action. And preferably it should be synergistic. There may be a situation that the drug itself is effective alone and there are 2-3 drugs which are effective alone. So if we mix them together, we can see what will be the effect. If they have synergistic activity, Very good. It is rather preferable. Another thing is that they should have different mechanism of resistance, so that resistance does not develop to the regime. Third, they should have different toxicities, so that there is no synergistic effect over the toxicities. So toxicity is important. They should have different profile of toxicity. And finally, I would say trial and error. The specialists, they keep trying different permutation combinations, and whichever comes out best, that is taken as a guideline. So trial and error. There are certain considerations when we said they may be synergistic, or we have to select which drug is to be used, and in that this is another important consideration. Some of the drugs are cell cycle non-specific, we say, and other drugs are cell cycle specific, because we know in a fast multiplying cell, what is G0? Resting cell. The cell is not multiplying, in hibernation. So that is phase G0, we call it. When this cell decides to multiply, this comes in phase G1. So this is pre-mitotic phase. The cell is readying itself for synthesis of DNA, S phase. So from G1, the cell will go in synthesis phase, that is DNA synthesis. When the DNA is synthesized, everything has taken place, then there will be mitosis. After mitosis, the daughter cells, they will go in this phase G2. Means again some post mitosis, some rest. And after this G2, they will decide whether to go for G0, hibernation, or to again come back to G1 and again multiply. So this is a cycle of multiplication. So some of the anti-cancer cells, anti-cancer drugs are cell cycle specific. Again, I can give you many mnemonics, but I give you a general method to remember. Synthesis of DNA. So remember all antimetabolites. Folic acid antagonist, purine antagonist, pyrimidine antagonist. Folic acid antagonist like methotrexate, pemetrexed. Purine antagonist like mercaptopurine, thioguanine, okay, fludarabine. They are all azathioprine. They are purine antagonist. Pyrimidine antagonist, cytarabine, 5-fluorouracil, they are pyrimidine antagonists. So they are all, if somebody asks you, you can enumerate. You can enumerate all these antimetabolites. They are specific to synthesis of DNA. Mitosis. Well, these drugs which are toxic to microtubules, they are all inhibiting the mitosis. So which are those? All these vinca alkaloids and taxanes, paclitaxel, docetaxel. Okay, so remember these are drugs which are toxic to microtubules. Otherwise, again, I used to remember a mnemonic in those days: windy pacer, vincristin, vinblastine, vinoralbin, docetaxel and paclitaxel. So windy pacer, I used to remember. But remember, they are all those drugs which are damaging the microtubule. So they will be selective to mitosis. And these topoisomerase, etoposide, topotecan, irinotecan, they are in phase G2. Etoposide, I'm talking about etoposide. Etoposide is specific to G1 also. So these topoisomerase inhibitors, they are All of them, they are selective to G2, etoposide, topotecan, irinotecan, and etoposide is selective to G1. Rest of them are non-selective. All alkylating agents, nitrogen mustards, ethylamines, nitrosoureas, all these alkylating agents, and the miscellaneous ones, even antibiotics, they are, but just remember some exceptions are there, like say bleomycin. Bleomycin is selective. So this bleomycin is selective to this G phases. But generalize, I have told you, generalize. All antibiotics, all miscellaneous, you can classify as them as non-cell cycle specific. So this is also an important consideration for making a regime, that we use drugs which are acting at different parts of the cell cycle, or if the if the tumor is growing very slowly, there is not much multiplication, there is not much mitogenesis, then what? We should go for non-cell cycle specific drugs, because they are in resting state, they are in G0, in slowly multiplying cells, and so their non-cell cycle specific drugs will be more effective. So with this you can find out some of the specific regimes which are there, and this covers the general considerations about anti-cancer drugs.